Introduction to Population Health. Years of rising costs have created the need for change in healthcare finance and delivery. The actors that bear those costs, from federal and state governments to employers and individuals, have reached the point where annual increases are financially unsustainable. Historically, the delivery system has been a fee-for-service model, where the more services provided to patients such as visits, tests, procedures, hospital admissions, and prescriptions, the more physicians and hospitals get paid. However, reforms have moved us toward a system where providers are rewarded for improving health while maintaining access to sick care within a fixed per capita budget. Such a population-based payment system is commonly called population health or payment for value. A successful population health system accomplishes three objectives. The population's medical outcomes improve when they are sick, the population's per capita costs decline, and the health of the population overall improves. Many organizations have entered into accountable care organizations, or ACOs, or have created patient-centered medical homes as a first step toward population health. These are important steps, but a successful strategy for health systems requires a more comprehensive approach. To transition from payment for volume to payment for value, health systems need to cross a shaky bridge. It shakes because of the uncertainty created for providers as the payment system changes. Doing what is right for population health has negative financial consequences when a majority of payment remains tied to volume. Successful strategies for providers crossing the shaky bridge need to coincide with changes in the payment model, creating a true population health system that brings the delivery and payment systems into alignment. Delivery system transformation focuses on quality and efficiency, alignment between hospitals and primary care providers, and rationalization of the service network. Payment system transformation requires providers to begin by managing care with their own self-funded health plans, contracting with payers that provide incentives for improving quality and lowering costs, then progressing to shared savings programs and ultimately full-risk payment arrangements. Throughout the process, rural health systems need to develop and invest in new capabilities like data analytics, care management, payer network contracting, value-based credentialing, and plan design that are critical to improving outcomes and lowering costs and are the foundation of a mature population health system. The videos in this series summarize the strategies for successfully moving across the shaky bridge by creating a true population health system. The videos in this series are based on the Population Health Transition Framework developed by Stroudwater Associates. Improve quality and efficiency. In order for rural health systems to move from payment for volume to payment for value and succeed with population health strategies, they must cross what we call the shaky bridge. We map out a strategy across the shaky bridge using the transition framework. This video provides details on part of that framework: improve quality and efficiency. Efficiency is the relationship between the quantity and cost of services. Value is the relationship between the quality and cost of services. Because population health is based on payment for value, this strategic initiative is one of the foundations for success. Delivery system transformation requires a continuous focus on improving the organization's internal operations, specifically efficiency and quality. Regardless of when or how fast you choose to move across the shaky bridge to population health, providers must invest in operational improvements to remain successful. Providers need to ask if they are providing the clinical services required to meet the needs of their communities, and need to continuously improve them to ensure high-quality, efficient delivery. They need to manage expenses aggressively and implement best practices in overhead and support departments. This may include working with providers outside their organization to achieve economies of scale and expertise. Quality and patient safety are strategic imperatives that, when done right, become strategic advantages. The medical staff needs to be engaged in quality improvement initiatives, and the organization's electronic health record is leveraged for this purpose. Efficiency and quality need to be ingrained in the organization's culture. This requires flexible, strong governance and leadership, decision-making at the right level within the organization, and a culture of data-driven decision-making based on outcomes measurement. The population health journey starts with ensuring that your internal operations are efficient and that your quality and safety programs are world-class. Beginning this strategic initiative benefits the organization in the volume-based payment system while creating the competencies necessary for success in a value-based environment. This align primary care providers. In order for rural health systems to move from payment for volume to payment for value and succeed with population health strategies, they must cross what we call the shaky bridge. We map out a strategy across the shaky bridge using the transition framework. This video provides details on part of that framework, align primary care providers. The way rural health systems align with its primary care providers and its community is incredibly important. Primary care physicians and advanced practitioners have long been the cornerstone of a community's health care. The value of these practitioners and their services increases in the transition to population health because they are the coordinators of care and the key to wellness and prevention programs designed to improve health status and reduce costs. Primary care practices also become the revenue streams of the future because in the future, payments will be tied to patients attributed to the practice. Alignment is achieved by creating interdependence between the hospital and the providers by recognizing the professional independence of a physician, whether employed or independent, and establishing mutually beneficial relationships. This relationship model creates a balanced, three-legged relationship based on shared governance, contractual agreements, and functional support. Ideal alignment strategies develop structures to address all three legs. Clinically integrated networks and physician-hospital organizations are examples of these structures. The strength of a rural health system's alignment with local primary care providers will increasingly dictate its future value and relevance. Having a well-aligned primary care provider network is critical for the advanced stages of population health. Therefore, necessary planning must begin now and be implemented quickly. Rationalize service network. In order for rural health systems to move from payment for volume to payment for value and succeed with population health strategies, they must cross what we call the shaky bridge. We map out a strategy across the shaky bridge using the transition framework. This video provides details on part of that framework, Rationalize Service Network. As the rural health system assumes greater accountability and financial risk for defined populations, it is important to develop network relationships that ensure appropriate access to care, limit care from out-of-network providers, and improve care transitions among providers. Rationalization of the service network requires removing redundant facilities, overhead, technology, and specialists from the network. Just as primary care providers become the revenue centers in population health, former revenue centers become cost centers and must be managed aggressively. The Service Rationalization Strategic Initiative is challenging because it has long-term implications for the community and requires negotiation between network partners. Strategic investments in resources are necessary to take advantage of changes in technology, medical practice, and demographics, with the goal of providing the right care in the right place at the right time. Such investments may be beyond the reach of many rural providers. Evaluating affiliation options as part of a system integration and alignment strategy is essential to achieving the long-term economic benefits of population health. Employer-sponsored health plans and fee-for-service payment with incentives. In order for rural health systems to move from payment for volume to payment for value and succeed with population health strategies, they must cross what we call the shaky bridge. We map out a strategy across the shaky bridge using the transition framework. This video provides details on part of that framework, employer-sponsored health plans and fee-for-service payment with incentives. Rural health systems need to maintain alignment between the transitioning delivery system and the developing payment system. The first step is to gain experience managing care for patients in the hospital's employer-sponsored health plan, where hospitals are already 100% at risk for the costs of care provided to a defined population. Reducing claims expense for your employees and their dependents has a direct positive impact on the hospital's costs. Begin by redesigning the plan to include incentives for employees and their dependents to receive care within your health system. The marginal cost of providing additional services within your organization is far lower than paying for care rendered by other providers. And plan redesign offers an opportunity to create incentives for a healthy workforce. For example, premium discounts can be offered to employees who meet goals such as smoking cessation or weight loss. For most providers, fee-for-service payments are already linked to incentives by Medicare and commercial payers. These programs offer financial incentives to engage patients more effectively and demonstrate value in an age of increased consumerism. Shared savings payment. In order for rural health systems to move from payment for volume to payment for value and succeed with population health strategies, they must cross what we call the shaky bridge. We map out a strategy across the shaky bridge using the transition framework. This video provides details on part of that framework, shared savings payment. The next strategic initiative is shared savings payment arrangements. The most common are Medicare ACOs, where cost savings are shared between the provider and Medicare. Medicare ACOs are likely to be transitional payment arrangements as Medicare gradually moves its covered beneficiaries to full-risk, capitated Medicare Advantage plans. Together with commercial insurers, rural health systems interested in shared savings arrangements must identify opportunities to be the network of choice for insurance products where there are strong steerage incentives for enrollees. Other opportunities include pursuing direct contracts with large employers where savings targets can be mutually established and savings can be shared between the employer and the rural health system. Successful participation in shared savings arrangements is built on the experience gained by managing the hospital's employee health plan through analytics and care coordination, but requires developing new organizational capabilities in creating effective provider networks and provider incentives. Full risk payment. In order for rural health systems to move from payment for volume to payment for value and succeed with population health strategies, they must cross what we call the shaky bridge. We map out a strategy across the shaky bridge using the transition framework. This video provides details on part of that framework, full risk payment. Providers entering into full risk payment arrangements with payers assume full economic responsibility for providing services to a defined population within an actuarially established budget. This is known as capitation. If the costs to provide those services exceed the budget, the provider suffers a financial loss. If the costs are less than the capitated budget, the provider keeps the difference as profit. A provider's ability to accept insurance risk requires scale in the form of attributed lives and a comprehensive service delivery network. Providers attempt to diversify their risk by aggregating a significant number of patient lives. More lives reduce exposure to adverse selection and lessen the impact of very expensive episodes of care. Individual rural communities are rarely large enough to achieve actuarial scale, so providers need to develop regional or statewide networks for this purpose. Rural health systems have incentives to keep as many services as possible in its local network because it's significantly less expensive on a per-unit basis than purchasing these services from non-network providers. Clear strategies must be developed for how services beyond the contracting network's capacity will be contracted and paid for. Create population health system. In order for rural health systems to move from payment for volume to payment for value and succeed with population health strategies, they must cross what we call the shaky bridge. We map out a strategy across the shaky bridge using the transition framework. This video provides details on part of that framework. Create population health system. When changes to both the delivery and payment systems become integrated into a single payment and delivery system with aligned financial incentives, the result is a fully mature population health system. As the payment system evolves, increasingly sophisticated capabilities and infrastructure are required to respond to, create, and transform the population health system. Identifying high-cost patients that can be most impacted by care management requires new types of analytics. Because care management seeks to reduce variation in the care of common diagnosis, evidence-based protocols guide care provided to patients with specific illnesses. The patient-centered medical home is a team-based model for primary care practices that supports care management. As providers assume greater risk, care management becomes increasingly important. Patients must be identified that can benefit from earlier intervention, mitigating complications and their related costs. Predictive analysis, or hotspotting, enables providers to identify these patients and to intervene earlier, keeping them healthier and avoiding unnecessary emergency department visits or hospital admissions. As they take on greater risk, rural healthcare systems must institute value-based credentialing to maintain high-quality, low-cost providers on the care team. At this stage, it is also important that the incentives in the payment system mirror the incentives to network providers by rewarding the providers for creating value. Basic insurance functions like sales, actuarial services, regulatory compliance, capitalization, out-of-network contracting, and reinsurance need to be developed. This process can be expensive, so each function must be evaluated to determine if it is better to make it, buy it, or partner with an insurance company. Several organizational models have been created that support this integration. For example, clinically integrated networks and community care organizations and provider-sponsored health plans.